Good evening, everybody. My name is Federico Stefanini. I'm an internal medicine specialist working in the internal medicine COVID-19 dedicated ward in Sant'Orsola Hospital in Bologna. Thank you for having me here. I'm going to start my presentation with the basic concepts in lung ultrasound. We're going to focus particularly on US interstitial syndrome, how it is called. But first of all, let me make two special thanks to two persons who are great experts on thoracic ultrasound and that I have had the pleasure to meet during my training in this topic. Dr. Roberto Copetti, who's the director of the emergency medicine department of Latisana Hospital and co-author in this book, which is called Thoracic Ultrasound. This book is like the Bible for many lung ultrasound enthusiasts like myself. Dr. Gianalfonso Cibinel is former director of the emergency department in Pinerolo Hospital, Italy, and he's now the chief of the CIMEO crisis unit for COVID-19 in Regione Piemonte. CIMEO is the Italian Society of Emergency Medicine, and who's also the author of the CIMEO guidelines on the emergency ultrasound in COVID-19. So, starting with the fundamentals. In this drawing, you see a picture of a normal lung that with ultrasound we are going to assess from the outside to the inside. So, starting from the thorax wall, at some point we see the pleural line, which is made by these two layers that we know, and then the lung field, the lung filled with air. What we normally assess from the outside is the cortex of the lung, which is the very peripheral part of lungs. These other drawings depict what the different pathological scenarios could be that we can assess with lung ultrasound. We are not going to talk about pneumothorax and pleural effusion, and we are going to focus our attention on interstitial syndrome and parenchymal consolidations, since these two are what is most important to assess lung involvement by COVID-19. Again, you see here a magnified microscope image of the lung cortex. This thin layer of tissue here is the visceral pleura. You can tell by yourself how thin it is. And then the alveoli filled with air with very few cells and solid material in between them. Just briefly reviewing the basis, as you very well know, with ultrasound we are capable of studying tissues that are similar to water in terms of acoustic impedance, and that makes it possible for ultrasound waves to travel across these tissues and have some waves coming back to the probe, so that we see those beautiful grayscale image that we all know. Some problems arise as we try to insonate other structures that have acoustic impedance, which is either very lower or very higher than blood and water. And these two are air and bone, basically. Since the amount of sound waves that are reflected back to the probe depends on the difference in terms of acoustic impedance at the interface between the two tissues, the two media, we cannot see what's behind because all the sound waves are reflected back by these tissues and materials. So what we have is basically a thin hyperechoic layer with acoustic shadowing behind it. So how is it even possible to assess lungs since they are so filled with air? This is a real image of our lung ultrasound. What we have as we put the probe on the chest of the patient, this is called the longitudinal approach, which means that the marker is headed towards the head of the patient and towards the left of the screen. So starting from the surface, these are soft tissues with fat layer and muscle layer, superficial and deep. And then we have these two hyperechoic lines, which are the ribs. So here is the intercostal space, here is the upper, and this is the lower rib. Behind the ribs, as we told, we find acoustic shadowing and we cannot see what's behind. This other hyperechoic layer here is called the pleural line. It is an artifact. It is made by the sum of the two pleural layers, so the parietal and visceral layer of the pleura, and the air which is just beneath it. The only real structures that we can see are these ones, so at the superficial layer. Everything which lies behind is artifactual. So even these images that we find here behind the pleural line are not real. They do not represent anything that is present in normal lungs. This is because with lung ultrasound we basically study artifacts. Largely, lung ultrasound relies on the study of these artifacts. So we shall now learn them. The first one we are going to assess and learn are A lines. As we saw, the pleural line is made by sound waves as they travel to the pleura and then are reflected back to the probe. But since here sound waves have so much energy left, they can be reflected back from the probe and they can travel the same distance twice. As they are read by the probe, the machine is going to depict not only the pleural line but also another line which is exactly the same at twice the distance. This is called an A line, and this process can repeat itself several times, few times, so we can have different A lines at always the same distance in depth. These other lines that we see here are not A lines, since they don't have the same distance from the probe to the pleura, and they are basically reflections of what is here. A lines are very useful because they tell that under this layer there is air, basically. It could be either in the lung, so a normal lung would show A lines, or free air, as in pneumothorax. This is a video showing the pleural line as it moves up and down as the patient breathes. This effect is called lung sliding, and it is also very important because it demonstrates that the patient is breathing, of course, and that the pleural layers are touching one another and they are doing fine. Lung sliding can be reduced. This is normally present at the apex of lungs, since they are less movable. It could be absent. Of course, if there is free air under the parietal pleura, we would not see the other pleural layer, the visceral pleura. So in pneumothorax, you wouldn't have any lung sliding. The lung sliding can also be reduced for infiltration or fibrosis of the pleura, or for consolidations, or if the lung is hyperinflated, such as in severe emphysema. Another sign that we could see is the lung pulse. Now you see the patient is not breathing, but we still see some movement. You see, this movement happens in synchrony with the cardiac pulse, because it is made by the mechanical force of the heart being transmitted to the two pleural layers. Again, if two pleural layers are touching one another, we could see the lung pulse. Lung pulse could not be seen all over the chest. It is best seen on the left chest, of course. It could also be abnormal, since it could be enhanced in case of severely congested or consolidated areas. Now, this is a picture of what we have as we put the probe on the lateral chest of the patient. This is the right chest. Since we see the liver, it could very well be the left with the spleen. So here is the liver that we know, and this curved hyperechoic line, it is the diaphragm. It is important because it separates what's the abdominal cavity to what is the thoracic cavity here. So this scan is important to assess the movement of the diaphragm that we are going to see in this clip right now, and to assess, for example, for pleural effusions which would appear at this level. Since we do not see these tissues going towards the chest, that means that this black area here is just an artifact. It is made again by the reflection of sun waves from the air which is under the diaphragm back to the probe. So this is not a pleural effusion. In pleural effusions, we would see the spine going here. So now, if the patient breathes in and out, we see this effect. Of course, this hyperechoic layer here is the air inside the chest, inside the lung, that goes down and up again. This movement is called the curtain sign, and it is also important to assess normality. Now, moving on to some other artifacts which are of crucial importance in lung ultrasound, which are the B lines. You see here these beams starting from the pleural line and going all over to the bottom of the screen. These are called the B lines. They are hyperechoic and they cover basically everything which is beneath them, including A lines. In this picture here, you see two B lines, and other things that are not B lines. This one does not start from the pleural line. This one is a comet tail that does not go to the bottom of the screen, and this other one does not delete A lines. Some other examples, here you see B lines, beams that travel all the way to the end of the screen, and some other things which are not B lines, such as these little comet tails here. Okay, but what are B lines exactly? We're not going to talk about the physics involved, but let me show this picture, which is quite famous. It is taken from the book from Dr. Copetti and Dr. Gino Soldati. You see, as we said, the cortex of the lung is basically air-filled. Its air content is much more than its fluid content. And what we see is the normal appearance of the pleural line and A lines in a black pattern, or it is called also A pattern. And the lung at this stage, when it is normal, it reflects 88% of the sound waves, so it acts basically as a mirror. But what happens if the lung loses aeration or its density increases? B lines would start to show. We can think of them as cracks in the mirror. They depict the lung de-aeration. Their number basically expresses the severity of the lung de-aeration. B line starts growing as the lung loses aeration, and they reach a peak in which everything we see in the screen is white, is B lines filled. These B lines become coalescent, and that is called the white lung. And till now, we have assessed something which is just artifacts made. This is called the interstitial syndrome. This is a mild interstitial syndrome. This is the most severe interstitial syndrome that we can see. But what if the lung still loses some air again and it increases its density? Then the reflection coefficient could be so low that the mirror could crack and we could see what's behind it. In this picture you see some pleural effusion, and then this tissue, which is totally like liver tissue. This is what is called a consolidation, So that means that the lung parenchyma, who's lost about all its air content, could look like a normal tissue, and that is a real image. Now we could measure this tissue and we would have consistent results. So as we reach a peak of interstitial syndrome, we could could reach the stage where consolidation appears. Here you have some examples. On the left, a normal A pattern still image on the clip. You see here you have one B line, which we do not normally consider important, not relevant. But as B lines start to grow, we could call this a B pattern. This is an interstitial syndrome of mild to moderate importance. As the process increases, we reach the white lung stage, in which everything is filled by B lines. You cannot see any A lines in these pictures, but you could see some A lines here and here. Some examples of consolidations, which are parts of the lungs which have totally lost their air content. Here you see a very little consolidation on the subpleural level, and here you see a very large consolidation involving all the base of the lung. You see this is the lung, which totally looks like the liver, which is here. The same image you could appreciate here. This is the lung, and this is the liver, so very similar. In this other picture, you see that inside the base of the lung, which is consolidated, we still have some artifacts made by the air, which is trapped inside bronchs. This is called the air bronchogram. This is quite important to assess also in COVID-19. To demonstrate that the interstitial syndrome is a spectrum, you see here consolidation, quite well defined, but at the periphery of these consolidations you have B lines arising. That means that the lung parenchyma here is compressed and inflamed. At some point it becomes consolidated. You already know this picture. The normal lung has a high air content. So how is it possible for the lung to lose density? It could be either for loss of air volume, such as in atelectasis, in which alveoli are shrunken, or if the fluid volume is more than normal, such as in extraalveolar volume or alveolar volume. That could happen for many different reasons. For example, pulmonary edema in the first phase would affect the septa, and then it would affect the alveoli as well, that would be filled with transudate fluid. In the interstitial fibrosis, chronic fibrosis, we see a thickening of the septa, and in pneumonia, not only transudate but an exudate and cells would fill the alveoli. Interstitial syndrome is what lung ultrasound can assess as a rise in lung density. In other words, lung ultrasound is a quite sensitive medium to study lung density. Each increase in lung density would be depicted as interstitial syndrome. So B lines would appear and grow till the white lung stage, and then consolidations. We now present some different causes of focal interstitial syndromes and consolidations. We're not going to talk about the differential diagnosis and how to tell these different causes apart, because we want to focus on COVID-19. So I would just present you some different cases. Here you have a normal A pattern, nothing happening here. Here you already saw this video. You see a consolidated area of the lung, which is caused in this case by pneumonia, and the B lines, interstitial syndrome around it. It could very well be also a lung contusion in the advanced stage, or rarely a surfacing neoplasm. a focal B pattern is what we have as we slide towards a different area of the lung. As you see at the beginning of this picture, you see some A lines in this intercostal space. Then we slide up with the probe and we see very focal interstitial syndrome with many B lines. That means that in this area, in this region, something is happening. It could either be the early stage of pneumonia or contusion or of atelectasis, or it might also be a deep sitting lesion that we are not seeing directly, because with lung ultrasound, and that is very important, we only study the surface of the lungs. We cannot tell what's beneath the surface if there are not indirect signs, such as in this case. You see here some small subpleural consolidations. These are signs of another pathology happening, but they are absolutely not specific of any one. They could happen in embolism or inflammatory diseases and so on. Some other examples of consolidations, specifically atelectasis, which could have two mechanisms. The first one and the most common is that compression atelectasis, which is made normally by fluid effusions that compress the lung parenchyma, making it look like a tissue. So as in this example, and you see that around the atelectasic lung, again, B lines are present to demonstrate that the consolidation is a spectrum. We go from normal pleura towards interstitial syndromes with many B lines, and then the consolidated lung. This is an extreme example of hydrothorax, a complete fluid effusion of the whole hemithorax, with the lung which is totally collapsed towards the hilum. The other mechanism is this desorption atelectasis. This is made by something which stops the air from reaching the end of the bronchi. That could be for mucus plugs or foreign bodies, such as in the endotracheal tube misplaced, or by malignant tissues. Some example of what we have in the end. This is a total atelectasic lung. Sometimes we could also tell the cause of this happening, such in this case where we see a malignant node appearing, surfacing the atelectasic lung. So we could even suspect a malignancy. As we said, that is very important to study what's to know what lies in the inner side of the chest. We need some indirect signs at the surface. We always have to keep this in mind. Now we present some other examples of interstitial syndrome. In this case, the interstitial syndrome is diffuse to the entire chest. The most important case that we have to study is the cardiogenic edema. In cardiogenic edema, the involvement of the lungs by the interstitial syndrome is quite typically diffuse, bilateral, and symmetrical. And it has a gradient, so it is more severe at the base of the lungs, and it is reduced at the as we reach the apex of the lungs. As you see in this picture, the base of the lung is atelectasic, since there is pleural effusion, which is very common, and sometimes it is very frequently actually it is bilateral. So fluid effusion, severe B-line, severe interstitial syndrome at the base, which becomes less severe as we go towards the apex, which could also be completely normal, as in this case. The same gradient we could see from the posterior to the anterior part of the lungs if the patient is bedridden for several days, as is most frequent in our medicine wards. It is B-lines such a sensitive method of studying cardiogenic edema that lung ultrasound could rule out diagnosis of a severe cardiogenic edema. In a severely dyspnoic patient with insufficiency, respiratory insufficiency, the absence of B lines could rule cardiogenic edema out. In a severe cardiogenic edema, what we would see is this pattern, so severe interstitial syndrome all over the chest, white lung all over the chest of the patient. And the B lines and the pleural lines normally in the cardiogenic edema are smooth until we reach a very severe stage of white lung. And that is very different from this other picture, this other pathological scenario, which is what we have in inflammatory lung diseases or fibrosis, chronic fibrosis of the lungs, such as in ARDS, acute leg injury, interstitial pneumonia, and so on. In this case, what we have is a completely random appearance of all the different pathological findings that we already saw. For example, here you have some subpleural microconsolidations. Here are more prominent consolidation in this part, which is quite common at the basal part of the lungs. And this interstitial syndrome has a completely random and spotty appearance. In this example, you see, as before, that there is a spared area depicted by these A lines here in this intercostal space, but as in here. But in this other intercostal space, you see a severe interstitial syndrome. That is not consistent with what we saw in cardiogenic edema, like here. So that hints to the diagnosis of something different. And the pleural line could either be quite smooth, as here, or very rugged, as in this case. And that is very typical. We have to keep this picture in mind, since it is very important also to assess COVID-19, which has an interstitial pneumonia phenomenon, pneumonitis, has this appearance. I put also alveolar interstitial syndrome here because sometimes we call this appearance of microconsolidations and thickening of the pleural line alveolar interstitial syndrome, which is like the stage in between interstitial syndrome and consolidations. So to approach interstitial syndrome and to make a good differential diagnosis, we must use this approach. We start by assessing if the interstitial syndrome is diffuse or focal, and then we try to understand the timing of the onset of this scenario, because if it is acute or it is chronic, it might have many different or very different causes. Then we have to have the clinical scenario in mind. For example, if we are studying medical or trauma patient, if the patient, for example, has fever or not, and so on. And then we use ultrasound as a pattern recognition tool to reach the final diagnosis. Going to the examination technique, as I said, there could be the longitudinal approach, in which the probe is put on the intercostal space, cutting it. And so in this case, we see the different intercostal spaces as we slide down towards the base of the lung to assess the whole surface of lungs. At some point, we are going to reach the base of the lung here and the liver or spleen, which is behind. Which is lower. And the other possibility, which is very important to in these patients, is the intercostal scan or transversal scan. We rotate the probe from here to the transversal approach, putting it in between the ribs. So what we see now is the pleural line in a much larger surface. So this is better to understand. This is better to understand the anatomy of the part and this to assess for pleural abnormalities. Then we slide down again towards the base and looking at each intercostal space. Of course, these lines that appear sometimes is the rib itself. So again, another intercostal space, and so on, another intercostal space till we reach the base here. Another possibility is to study the diaphragm from the abdominal cavity using the liver or the spleen as acoustic window in the transhepatic or in the lateral scan, as we already saw. It is important to assess all the surface of lungs. So to make it our exam repeatable, we need to know where we are and how to report the different abnormalities that we find. This is an example of a 12 zones approach, which is very commonly used. We can divide the chest of the patient in an anterior part, lateral part, and posterior part, and the border being the posterior and the anterior axillary lines. Then this area can be cut in two, one upper and one lower. So we would have 6 regions for each hemithorax and 12 in total. The same could be done obtaining 14 zones as we cut the dorsal area in 3, because here the lung is higher, has a more surface, so we could also use 3 different zones. And then we would have 7, 2 times 7, so 14 zones. But this is only possible if the patient is standing or sitting. If the patient is bedridden, then sometimes we could just use 8 zones approach, 1, 2, 3, 4, anterior and lateral. And that could be of some importance, of some utility. For example, in the emergency setting, if we have to rule out cardiogenic edema, this is totally fine, this is sufficient. But if we want to study the whole surface of lungs, as sometimes happen, then we would try to make some effort to study what's behind the posterior axillary line. And so maybe rolling the patients over to study at least the lateral posterior area, which is very important, for example, in COVID-19 patients. About the choice of the probe, we normally use the convex multi-frequency abdominal probe as our go-to tool for most lung ultrasound applications, since it has the best panoramic function. And it has a good ratio between resolution and depth of field. Then the linear probe could be used to, for some applications, to add sensitivity to our exam. For example, if we want to study little pleural line abnormalities, if we are looking for pneumothorax, or to study the chest wall and the diaphragm. The phased array, the cardiac probe, is optimized for echocardiography, which is very important if we can do it to complement our lung ultrasound study, but it is not ideal for most lung ultrasound applications beside emergency POCUS, so it would be our third choice. Just some hints about machine settings. Normally we set the depth of view of the field to about 10 centimeters to better assess B lines, and then we reduce the depth to assess little pleural abnormalities, or we switch to the linear probe. One point focusing should be used, no multifocusing, setting the focus point on the pleural line depth. Then we try to lower the dynamic range to obtain more sharp images and blacks, and we try to disable or reduce filters such as compounding or harmonic and so on, and we lower the persistence so we have a better time resolution of the image. But the end point is, bottom line is that you have to try all these different settings because the machines can differ, and so try by yourself what is best for you, what works best for you. So, conclusion to this introduction, practical suggestions when approaching interstitial syndrome. Always have the clinical picture in mind, because lung ultrasound cannot be used alone. It always must add something to our clinical analysis of the situation of the patient. So know your setting, have a question in mind, and know your limits. For example, if we are looking for something very specific, we could just use a quick look to rule that thing in or out, such as in cardiogenic edema, as we said. But if we want to assess the whole surface, then we would take our time and make an extensive exploration of the lungs. Use both longitudinal and intercostal projections to add both anatomy recognition and pleural line sensitivity. Access B lines in terms of their number, if they cover more or less than 50% of the screen in an intercostal projection. Note the distribution if they are focal or diffuse. And how if there is a pattern such as we saw in cardiogenic edema or not. Assess and look for consolidations. Note accessory pulmonary features such as pleural effusion, its severity, air bronchogram, inside consolidations, and if the lung is correctly sliding. Then, if you can, use multiparametric point-of-care ultrasound to assess different things, such as the volume status of the patient, which is very important. So basically, we look at the inferior vena cava and try to make an impression of how the volume status of the patient is. And if you are an experienced operator, you could also study the cardiac function, which is of very importance in many patients. So that will be all for the introductions. Next chapter will try to cover some of the characteristics of US patterns in COVID-19 pneumonitis, for what we could assess by ourselves during these weeks in the hospital at the COVID-19 dedicated ward.